This series was designed so that the CDC investigators can share their lessons learned so that others may be inspired to carry on their work. And I would also like to welcome you all today. And joining us from the Food Safety and Inspection Service, USDA, and the FDA, they're joining us from Washington. I'd like to extend a special welcome to them. And without any further ado, I'd like to introduce Rima Kabaz, the Deputy Director for Infectious Diseases at CDC.
Thank you, Phoebe, and welcome everyone. While this infamous outbreak of E. coli O157 occurred in 1993, the story actually begins much earlier, back in 1982. That's when CDC laboratory scientists intensified their efforts to find a pathogen responsible for bloody diarrhea and identified E. coli O157 as a cause of human illness. Prior to their work, E. coli O157 was considered a rare organism that was generally not even tested for. However, CDC microbiologists noticed the same E. coli kept growing in stool cultures from individuals with bloody diarrhea and made this crucial link. And by the time of the Jack-in-the-Box outbreak, we had already learned that E. coli O157 produces a toxin capable of damaging not just the intestines, but also the kidneys, and leading to hemolytic uremic syndrome, or HUS, and death. So other parts of the story follow what happened during and after the Jack-in-the-Box outbreak. Across the US, TV networks and newspapers showed pictures of children suffering in hospitals and clips of distraught parents saying they had just taken their children out for a hamburger. Americans realized that if one child could become deathly ill from eating a single hamburger at a fast food restaurant, all our children were at risk. The outbreak, along with the public's outcry, drove a shift in food safety that many at CDC and regulatory agencies had been working toward for years. This was an enormous shift. So from just focusing on the consumer's role in making sure our food was properly handled and cooked, to also focusing on the role of food suppliers in making their products safer. So how did CDC and public health respond to ensure food safety? Foremost, the government passed a rule to improve meat safety and allocated funding to CDC and other agencies to help them and state health departments detect and respond to foodborne illnesses. You're probably familiar with two of the CDC systems that were developed at the time. One is PulseNet, a system that tracks foodborne illnesses, determines risk factors, and measures the effects of prevention. And another is PulseNet, a laboratory system that uses bacterial subtyping to detect outbreaks, including multi-state ones. You will hear more about PulseNet and PulseNet in today's presentations. Both were revolutionary at the time and have been quite successful in the past 20 years, identifying more outbreaks and sources of food contamination and leading to decreases in some infections like E. coli. A major part of the story as well is the collaboration that occurred and continues today across CDC and with colleagues at state health departments and other federal agencies. Important recognition also goes to the parents and other members of the public who work to prevent such an outbreak from happening again. All of these individuals worked to turn tragedy into something we all benefit from, safer food. In today's presentations, there are many photos of individuals who contributed to this effort. Some are so young looking that hopefully if you know them, you'll recognize them. Thank you.
So in January 1993, the intensive care unit at the Children's Hospital in Seattle was flooded with children fighting for their lives. Unknown to their doctors, similar scenes were occurring in other states. Today, we'll tell you about an outbreak of Escherichia coli O157 infections linked to fast food hamburgers that resulted in at least 744 people ill, mostly children, 199 hospitalized, 56 with kidney failure from hemolytic uremic syndrome, and the deaths of 4 children. After some background, we'll tell you the Jack in the Box restaurant outbreak story, including the investigations in Washington, Las Vegas, and San Diego, and the meat and lab investigations. We'll explain how the outbreak led to the birth of PulseNet and a paradigm shift in food safety. Finally, we'll discuss lasting impacts on foodborne illness surveillance and investigation and the impact beyond food safety. So first, I want to go back 11 years before the Jack in the Box outbreak to February 1982, when an outbreak of a new syndrome occurred in Oregon. Patients had grossly bloody diarrhea, severe abdominal cramps, and little or no fever. Most were hospitalized, but tests of pathogens in the stool were negative at the clinical and at the public health labs. So epidemiologists from the health department and CDC determined the source was specialty hamburgers at several outlets of the same fast food restaurant chain. Many CDC labs collaborated to find the pathogen, and we see this still today when there's an unknown pathogen. There's an all-out effort. They sought bacteria and viruses. They did serotyping, subtyping, virulence assays, and molecular analyses. Joy Wells coordinated this effort. Her epidemic investigations lab isolated bacteria not known to be pathogens, a Klebsiella, a Bacillus, and an Escherichia coli O157H7, a very rarely identified serotype that had no known virulence factors. But still, Joy suspected that it might be the cause. But they'd only tested 6 patient stool specimens. So she certainly wasn't sure, and she wasn't able to convince others. But 3 months later, a similar outbreak occurred in Michigan of the same unusual syndrome, linked to the same fast food restaurant chain, with the same results at clinical and public health labs, no pathogen. So Joy's lab again detected bacteria not known to be pathogens, a Klebsiella, a Bacillus, and that same E. coli. Further analysis showed that the Klebsiella and the Bacillus from different patients looked different by various tests, but the O157 strains all looked similar. So the investigators gathered further evidence that O157 was the cause of this new syndrome. It was not isolated from healthy people in the same neighborhoods. It was isolated from a hamburger patty from a suspected lot. And CDC records, and you can see along the bottom the records, of over 3,000 E. coli found that it had been isolated once before, and that was in 1975, you see the record book, from a 50-year-old California woman with bloody diarrhea. Very suggestive. So the next year, it was shown to produce a toxin by Johnson and Carmali in Canada and O'Brien in the United States. So CDC called the syndrome hemorrhagic colitis, but some others started calling it hamburger colitis. And people were asking 2 questions. First, how common was this disease? And Rob Tokes is going to talk about that. And second, why had this pathogen emerged? Well, we still don't know that answer. One clue may be that it emerged in highly industrialized countries where agriculture and eating habits had markedly changed over the past century. So here's a brief reminder about those changes. During the 1900s, U.S. agriculture underwent many changes. During the 1950s and 60s, fertilizers and new techniques enabled farmers to plant vast fields of corn and soybeans So cattle could be fattened in these big feedlots, and they would eat grain instead of grass. And antibiotics were found to promote growth of cattle, so cattle got them routinely in their feed and water. So beef from hundreds of cattle was ground together, and meat on the surface could be contaminated by a dirty hide or by a dirty floor. And a single patty could contain meat from hundreds of cows. And contaminated meat that started on the outside of a carcass could end up inside a hamburger because the meat had been all ground together. So the ground beef went to the proliferating fast food hamburger restaurants, which we would later learn provided a really efficient delivery system for O157. So now we'll have Rob, who arrived at CDC as an EIS officer in 1983, the year after Joy identified O157 as a pathogen, and he'll talk about what changed after that discovery.
Well, I was fortunate to be able to join this small group led by Paul Blake, and we thought many questions needed to be answered, and a lot of them were working on it already. How widespread was the infection? On the right, you can see Lee Riley, who had been the EIS officer that investigated the first outbreak in Oregon, and he was working with states now, collecting stools from people with acute bloody diarrhea and getting them to Joy wells so they could be cultured. And the map rapidly filled in from Alaska to Florida. It wasn't hard to find. But how common was it really? Another EIS officer who joined at the same time I did, Chris McDonald, was working on a study with Washington State and with the Seattle Health Maintenance Organization that was looking for E. coli O157 every time a patient was cultured for Salmonella or Shigella. And it was astoundingly common, even more common than Shigella. And how bad could the disease get? The following year, I and EIS officer Caroline Ryan flew to a small town in Nebraska where there was an outbreak underway at a nursing home. Of 101 residents there, 34 were ill, and while some of them had mild symptoms, 14 were hospitalized and 4 of them died of acute kidney failure and stroke. That was a fatality rate of 12%, remarkably high as untreated typhoid fever. And that outbreak was linked to ground beef, just like the first ones were. So another question was, where did E. coli O157 hang out in nature? Was there an animal reservoir? In 1986, the Minnesota Health Department told us of two young children hospitalized with HUS. Each had separately visited grandparents on dairy farms in Wisconsin, where they had drunk raw milk. We thought that might be a good place to look, and soon 2 EIS officers were on their way to visit those 2 farms with Wisconsin officials. The grandparents of the patients were concerned. They also wanted to know how this could have happened. And they said the cattle were all healthy, but invited us to culture them. And so here's one of the EIS officers, Mary Louise Martin, swabbing a cow. It may seem obvious now, but it was a very exciting moment when Joy Wells told us that she had isolated O157 from cattle on both farms. So that meant healthy cattle could carry O157 in their intestines. And by the way, I have to digress for a moment. In 1998, Mary Louise Martin died tragically in the Nairobi embassy bombing. And in fact, the road that runs just outside this building is named in her memory. So in 1987, after a large statewide outbreak, the state of Washington made O157 a reportable infection, the first state to do so. Still, very few clinical labs looked for it in most parts of the country, and outbreaks were rarely detected. And in the first 10 years after that first discovery, we knew of only 15 well-investigated outbreaks in the U.S. Most were from beef. 2 were due to spread from child to child, and 1 was from a town water supply that got contaminated. Press were generally not very interested, and while regulatory authorities had started considering better control options, many thought the main task was just to convince people to cook their meat. Frankly, not much changed in that decade. Then, in 1993, came an outbreak that changed everything. Dr. Bell, you were the EIS officer. You were the EIS officer in Washington State when that call came in.
Thanks, Rob. And as Rob said, I was the EIS officer. I'm waiting for the laughs here. I don't look at that. Assigned to the state of Washington at the time of the outbreak, and the detection, investigation, and follow-up really defined my EIS experience. As the outbreak and the investigation progressed, what I had been taught in the July introductory course that all the incoming EIS officers participated when they first arrived in Atlanta really unfolded in the real world. I saw the power of an outbreak to challenge assumptions and to show why public health really matters to people, and how good surveillance, laboratory capacity, and timely reporting really do make a difference. And we join EIS to learn about field epidemiology, and we tend to get very focused on our outbreak investigations and the data we generate. But this outbreak showed how how it's not just about the data, and the enormous influence of the public, the industry, the press, and healthcare on the course of an outbreak and subsequent events. As I tell the story of this outbreak, as I lived it, there are three key points that I hope to bring out. How the pressing need to act to stop the outbreak and save lives drove our approach. We were constantly asking the question, what information was necessary to accomplish this goal? But the investigation didn't stop with the identification of the source and the recall. Sorting through the details of exactly how it happened, as best we could, yielded incredibly important information for investigations in other states, and also to focus on what was needed to be fixed to prevent this from happening again in the future. And finally, an awareness of the perspectives of all the stakeholders and players and their connections helped to set the tone of the interactions, not only during this outbreak, but also going forward. So now to the outbreak. So to set the stage, it was early January 1993, 3 months after the publication of Joshua Lederberg's Emerging Infectious Diseases report and just before Bill Clinton was taking office. We were heading into the Martin Luther King weekend. My sister was visiting for the weekend from California, and we were getting ready to go cross-country skiing. I had just finished commenting to her that I wasn't sure how worthwhile this EIS thing was going to be because nothing much seemed to be happening. When the phone rang. Phil Tarr, a pediatric gastroenterologist at Children's Hospital in Seattle with an interest in O157, had just called John Kobayashi, the state epidemiologist who's actually with us today, reporting that there were 2 hospitalized children with hemolytic uremic syndrome, HUS, on dialysis in the hospital. This was considered to be quite unusual in the winter months, as O157 was generally seen in the spring and summer. He had verified with his pediatric GI colleague that he also had been receiving calls from pediatricians in Western Washington who were treating children with painful bloody diarrhea. And Scott Dowell, EIS 93, and a pediatric resident at Children's Hospital at the time, overheard this conversation and dropped by the ED to discover that 3 children had presented over the last 24 hours with acute bloody diarrhea. In 1993, Washington was arguably the most likely state to detect an O157 outbreak. Previous outbreaks in the state had raised awareness among clinicians, especially pediatricians, and it was made reportable in 1987, the first state to do so. The 2 tertiary care hospitals in Western Washington screened all submitted stools for O157, and most clinical labs in the state were actually able to test for it. The state reported about 200 cases a year. So we swung into action. We called all the local health departments in the state, asking about cases of bloody diarrhea and requesting that they call us directly with updates. We developed a hypothesis-generating questionnaire informed by conversations with parents of hospitalized children that my colleague Marcia Goldoff had conducted. We developed a case definition and interviewed people with bloody diarrhea, or HUS, since January 1st. 27 of 37 initial interviewees reported eating at a Jack in the Box restaurant during the 10 days before they became ill. There was a surprising absence of clustering. The reported exposures were at restaurants distributed widely across the state. John Kobayashi, and I hope you'll hear more about this from him, kept the company well informed of the findings as we developed them. So although these results were compelling, we felt we needed to do more to answer the compare to what question. So we did a case control study on January 16th and 17th, using the first cases we had identified and controls who were neighborhood friends of cases matched on age. Here are the results of that study. As you can see, 12 of 16 cases, 75%, reported eating at a Jack in the Box restaurant referred to as Chain A here, compared to none of the controls, yielding an undefined matched odds ratio. Importantly, there was not even a hint of an association between two other fast food restaurant chains that we asked about and several types of meat. I was sitting at a computer at the health department, literally entering data as we generated it and calculating the odds ratios. While we were doing the case control study, cases were pouring in from local health departments around the state, and Phil was calling us as more children were admitted with HUS. So our sense of alarm and need to act were increasing. We had many discussions about how certain did we need to be, what was an adequately compelling odds ratio, did we need to pick a number, when could we act? In the end, that none of the controls, even friends, and concern had been raised that by using friend controls we risked overmatching, reported eating at a Jack in the Box restaurant was particularly convincing to us, and we stopped the study when we had information on controls for the first 16 cases. On January 18th, we acted to stop the outbreak. Here's a copy of the press release we issued. There were, by that time, 7 children at Children's Hospital with HUS on dialysis and 50 reported cases. Also on that day, the company issued a voluntary recall of all hamburger meat in Washington. Their press release is on the right-hand side of the screen. Again, it's perhaps not legible, but the first phrase reads, "Although it is unclear as to the source of an illness linked to undercooked beef," we are recalling. That day turned out to be particularly challenging because there was a very large, almost statewide power outage, leaving the health department in Olympia in the dark. And it was really only because the infectious disease division of the state health department, where we were based, was located at the state lab that had auxiliary power, that we were able to function at all. John Kobayashi was just telling me last week how he remembers coming home at the end of a very long day, listening in the dark to a phone message from an agitated Jack in the Box executive, but luckily that was sorted out, I think, the next day when power was restored. As I mentioned, it was very important that the investigation continue after the recall, and I can testify to the fact that we remained extremely busy for some time. I didn't take a day off, including weekends, for months, and nor did a lot of other people. One of the areas we focused on was understanding some of the remarkable findings that continued to be evident as the number of cases rose. First was the predominance of children. In the end, the median age was 8 years, and 75% were younger than 18. Almost all reported eating the smaller size hamburger at the restaurant, termed a regular burger, and the company had sold 2 burger sizes, this regular, which was included on the children's menu, and a larger jumbo burger, which was sold under a variety of names, and actually at the time the company had a big advertising campaign about their monster burger. Also remarkable was the absence of clustering among restaurants. There were cases associated with 91% of the 64 restaurants in the state by the time all the data were in. With the company's cooperation, we visited the single warehouse that supplied all the restaurants in the state, and we also visited several individual restaurants. We found that 90% of the recalled hamburgers, a total of 255,000 pounds, had been produced in a single lot on November 19, 1992. A review of the cooking practices at the restaurant we visited showed that the procedure, using a timer to cook each regular burger for 1 minute on each side, left parts of the burger pink and with internal cooking temperatures below the recommended temperature in Washington State at that time. The press interest, both locally in Washington State as well as Washington, D.C. and elsewhere, was intense. Here are just a few examples of the local press coverage, and certainly communication was key. John Kobayashi was the single spokesperson for the state and point of contact for the outbreak, and he was completely occupied for a period of weeks with talking to the press, using the opportunity to promote public health messages like the importance of hand washing to prevent secondary cases. Because of the intense interest in Washington, D.C., it was really important that there be seamless and very timely communication between myself as the EIS officer on the ground in Washington State and Patty Griffin, who was leading the investigation in Atlanta. In those days, the so-called laptop that EIS officers received was a 40-pound compact computer that definitely did not fit on my lap anyway. And so we were using a dial-up modem to get email and such. So I had both my Washington State desktop computer and this compact behemoth thing set up on my desk, and Patty would call and leave a message saying, check your email. And I would dial up on the compact and get into my CDC mail account to see what information she needed at that particular moment. So to summarize the course of the outbreak, the meat manufactured on November 19th to 20th was contaminated. On January 12th, Phil Tarr notified the health department of cases, hospitalized cases. On January 17th, we finished our case control study that implicated Jack in the Box. On January 18, we notified the public and the company recalled all of the hamburgers. And in the end, in Washington State, there were 639 people ill, 172 people hospitalized, 45 people with HUS, and 3 children died. About 2/3 of the contaminated meat had not yet been consumed and was recalled. And so we estimated that the recall prevented an estimated 800 primary cases. So thank you very much for your time. And now I'll turn the podium back to Patty, who is going to describe related investigations in other states that developed after the Washington State outbreak.
So as you can imagine, the outbreak in Washington gathered national attention. The new president and agriculture secretary assured the public that the system would be changed to make meat safer. The tension was good because we were worried that meat might have been distributed beyond Washington. So we faxed a letter to all state health departments asking them to report cases of bloody diarrhea and HUS. This graph shows all the ill people we eventually discovered. The x-axis shows the date they were ill, the y-axis shows the number of illnesses. The orange is Washington, those cases that Beth just showed you with the orange clearly had the most illnesses. Ill people also lived in Nevada, California, and Idaho. The epidemic curve peaked, as you see, the day after the recall, when 62 people in 4 states became ill. We had 5 CDC field teams by late January. Beth discussed the Washington investigation. I'll talk about Las Vegas, San Diego, and meat investigations. We won't discuss the daycare investigation. The epidemiologists were on the 5th floor of Building 1. The lab was in the basement. When there was an outbreak, one of us in the enteric diseases branch supervised the CDC part of the investigation. This one was mine, and things were really hopping. The White House demanded daily reports, and the press was finally interested in this pathogen, and we did lots of media interviews because we wanted this attention. I was also busy with a 3- and 4-year-old. So at the end of the day, I would play with my kids, put them to bed, and then go back to my computer at CDC, because we didn't have a way to link to our computer from home then, to have conference calls and work on questionnaires, talking with the people on the East Coast, on the West Coast. The days and weekends were exhausting and exhilarating. And as Beth said, this went on for months. So first, the investigation in Las Vegas. On January 21st, the mother of a 4-year-old girl with HUS told her pediatrician the girl had eaten at a Las Vegas Jack in the Box. The pathogen that caused her illness was not known, but the pediatrician called the county health department anyway and just said, well, just thought I'd let you know. Well, the health department acted quickly. The next day, they issued a press release asking anyone with bloody diarrhea to call. They were flooded with over 300 calls. And that was happening over the weekend. By the next Tuesday morning, they called me to request an EpiAid. So I ran down, everything was around the same building then. I was in building 1. I ran down to the auditorium where Paul Cieslak was in the EIS Tuesday morning seminar. I pulled him out and I said, you're leaving this afternoon. So he was on a plane on an EpiAid that afternoon. So he joined the investigators in Clark County, Las Vegas, and together they figured out how many cases were in Las Vegas. So here you see the cases of illness in Las Vegas in yellow, dwarfed by the ill people in other locations in blue. So in the next slide, I'll show you just the Las Vegas cases. So here I just, the 58, you can see the 58 Las Vegas cases on a different y-axis. So actually the Las Vegas part of the outbreak alone would have been one of the bigger O157 outbreaks identified up to that time. Yet it would have been missed without the county's press release. No one was confirmed as having O157 during the outbreak. So before Paul left, he asked physicians to culture patients when they came for follow-up appointments to see if we could get the O157 out of anybody and see if it was part of the outbreak, for sure. So the investigators linked illness to Jack in the Box restaurants. Their case control study showed that the regular small patties were linked to illness, just as in Washington. They used random digit dialing to find age and sex match controls. This is a very labor-intensive process, and it sometimes took over 200 calls to find a control person. I talked to Paul recently about this and asked him what he remembered, and he said, it didn't take me long to realize that whenever I called a home asking for an age and sex match control for a little girl, I was finding that none lived there. So I asked some of the women in the health department to do those calls, and they came through. So the study also showed that about a quarter of ill people ate only a jumbo patty. This was a surprise, and this helped the meat investigation team, which then found out that jumbo patties were also contaminated, and that Washington got only regular patties from the suspect lots. The median age of patients in Las Vegas was 31 years, compared with 8 years for Washington patients. It was a hidden epidemic in Las Vegas because no one had a culture for O157 while ill, because the Las Vegas labs didn't culture for O157, not routinely. And some cases were probably not identified because we only counted people with bloody diarrhea or HUS, and we know that O157 can cause non-bloody diarrhea. In fact, of the 35 people we interviewed who ate at Jack in the Box restaurants with people who later became ill, 20 of them said they had symptoms, and in fact, 2 of them met our case definition. So now I'll talk about the investigation in San Diego County. So San Diego invested their O157 cases when they heard about the Washington illnesses. CDC sent Abby Sheffer and Denise Koo on an EpiAid to join investigators there. They're both in the audience today. So the San Diego investigators found ill people by taking calls from patients, physicians, and labs, and they also reviewed medical records. They found 34 cases of illness, 7 with HUS, and 1 child, Lauren Beth Rudolph, died. Their case control studies also linked illness to regular patties at Jack in the Box restaurants. Only San Diego identified cases in California, yet the implicated meat was distributed to 400 California Jack in the Box restaurants, only 20% of which were in San Diego. But in California, few labs cultured for E. coli, and O157 and HUS were not reportable diseases. Only San Diego made active efforts to find cases, and people almost surely became ill in other parts of California. This outbreak was a mandate for improved surveillance throughout the United States. So next I'll tell you about the meat investigation, which took 4 weeks in the field, mostly in California. On January 24th, EIS officer Jessica Tuttle and Tom Gomez, who was USDA liaison to CDC, flew to Los Angeles to begin the meat investigation EPI-8, and they're both in the audience today. They reviewed records to determine how meat could have been contaminated and which lots were contaminated. They started in Los Angeles at the patty-making plant, and they worked backwards. The records led them to a plant where meat was removed from bones. We call that a boning plant. The boning plant records led to 5 U.S. and 1 Canadian slaughter plant. They visited the 5 U.S. plants, 4 in California and one in Salt Lake City, Utah, and observed risky practices in some. They also found records of risky practices. This report, the part below the line, if you can read, it says, carcasses being contaminated by touching the floor, employee raised the carcasses but failed to trim contaminated parts. Remember I talked to you about things on the outside being ground so that they become part of the meat on the inside of a burger. So state, federal, and academic labs found the outbreak strain in suspect lots of patties identified by epidemiologists. The University of Georgia's Mike Doyle isolated the outbreak strain from regular patties from 6 lots produced on November 19th and from a jumbo patty produced on November 20th. Lot 12 of regular patties was the most prominent one in Washington during the outbreak. 3 of 4 patties that Mike's lab tested yielded the outbreak strain. Lot 12 had the highest number of O157 organisms of any of the other lots. Mike estimated that that lot had 675 O157 bacteria per patty. This number was likely lowered further by cooking, and some children, like Lauren Beth, ate only a few bites. But the standard cooking procedures did not kill all the E. coli. This slide shows a hamburger patty cooked on a grill at a Jack in the Box outbreak in 1993 using their standard procedure. 6 of the 7 patties that restaurant personnel cooked for our team had temperatures below FDA's recommended 1 at the time, which itself was insufficient to kill all E. coli. The company collaborated with investigators. They designated a point of contact who facilitated investigation of beef records. They demonstrated cooking practices, as you've heard, on their equipment. They released positive O157 results from their contract lab. They offered to pay medical bills, and lawyer Bill Marler worked out the settlements. They hired Dave Thino, who improved meat safety at Jack in the Box and encouraged others in the industry to follow his lead. He was not popular with the industry for a while. In 2004, Jack in the Box received the Black Pearl Award for Excellence in Food Safety and Quality by IAFP. This is the Oscars of the food industry. So now I'll tell you about subtyping of outbreak strains. Tim Barrett tried pulse field gel electrophoresis. Others said that PFGE showed few differences among O157 strains. Tim found enough differences to determine that isolates from 4 states and patties were the same strain and that other isolates looked different. So here's Tim's gel, and I'll just take you through it. Lanes 2 through 5 have patient isolates from 4 states. Lane 6 has an isolate from a patty. Lanes 7 and 8, you can see, have different patterns, and they have O157 isolates unrelated to the outbreak. PFGE typing provided critical evidence for the Las Vegas investigation. A man in Las Vegas submitted a stool specimen 38 days after his illness began. The Las Vegas lab isolated O157, sent it here, and Tim showed it was the outbreak strain. This was the only lab evidence that the Las Vegas patients were part of the outbreak. PFGE also confirmed the outbreak strain had been transmitted from one person to another. Riley Detweiler had HUS, and his stool culture yielded O157. He never ate a hamburger, but attended a daycare center with an ill child. PFGE showed the outbreak strain that caused the illness and led to his death was the outbreak strain. So the likely sequence of events was that beef was contaminated with feces from cow hides, contaminated meat pieces were ground with other meat, distributing contamination to 2 days' production. Most was made into regular patties marketed to young children, some into jumbo patties. The patties were distributed to many Jack in the Box hamburger restaurants where the chain's standard method was insufficient to kill O157. This resulted in 744 ill people, 199 hospitalized, 56 with HUS, and the deaths of 4 children. So now Swami is going to tell us about how this outbreak led to the birth of PulseNet.
Thank you, Patty. I came to the foodborne diseases branch after the outbreak investigation was over. And when I came to the branch, Tim Barrett was investigating the use of pulse field gel electrophoresis for subtyping E. coli O157. He was comparing O157 isolates that were epidemiologically linked to the outbreak with non-outbreak strains that were isolated in the same areas as the outbreak during the same period. Dr. Barrett had prepared a manuscript on his work, and I was reviewing it. As I was reviewing the manuscript, and Patty has already shown you this slide, and I was focusing on this particular figure in his manuscript, it really intrigued me that pulse field gel electrophoresis did some great things that could be useful for epidemiologists. For example, as Patty pointed out, lanes 2 through 5 are patient isolates of E. coli O157, and each of these lanes represent the DNA fingerprint of that E. coli O157. And so what it shows is the outbreak strains are indistinguishable from each other. The 6th lane is also important because that is the hamburger isolate, and PFG shows that the hamburger strain matched the patient isolates. And as Patty pointed out, the other 2, lanes 7 and 8, show isolates that were not related to the outbreak, and you can see they were very different. So I said, PFG is showing me 3 things here. 1, you could identify a cluster of cases using PFGE. 2, you could, when the epidemiologist hone in on a source of the outbreak, we can confirm that by isolating the organism from that implicated source and then conducting PFGE. And then the third and probably the most important point is we could rule out those isolates from patients from the same areas as outbreak but not related to the outbreak, and thus really helping our epidemiologists with the all-important odds ratio. So I said we've got to do this in real time to be useful, not sporadically or in a retrospective fashion. But neither PFGE nor us was ready for this real-time or prime-time application to aid epidemiologic investigations. Because, number one, CDC really did not have the capacity to perform PFGE on all isolates in real time. Tim really had only one person helping him, and he was quickly overwhelmed by the requests from the state health departments. The second problem was PFGE was more of an art than science at that time, and there were variations in the way the patterns showed up from gel to gel, from day to day, and from operator to operator. So we still had quite a bit of work on this to do. And the third thing was that the comparisons were done visually, so one had to look at these gels or the photographs of the gels and then going through each lane and compare and say this is indistinguishable from lane 2 is indistinguishable from lane 3, and lane 4 is indistinguishable from lane 3, and so on. But that gets really tedious when you have hundreds or thousands of gels to look at, so really needed an objective way of scoring these things. So we then decided that we must focus on developing a real-time PFGE system, and we thought the best way to do that was to transfer the PFGE capability to state and local health departments. Our idea was that the clinical laboratories would send the isolates to the state health departments or the local health department, and they would do the PFGE analysis and then send the results to CDC. But to do this, we had to accomplish many, many different things. We had to modify the PFGE protocol so that it could be completed in 24 hours. The 4 to 5 days that it required for the conventional PFGE was just not acceptable. We had to standardize the PFGE to minimize that variations that I talked about. And we had to develop a robust and stringent quality assurance process for participating laboratories. We also needed to devise an objective means of normalizing patterns and comparing those normalized patterns using some kind of a software. And we had to set up a dynamic database of PFGE patterns at CDC in a repository so that incoming patterns could be compared to our database. This all sounded so far-fetched and preposterous that many of our colleagues compared us to Don Quixote slaying at windmills, but we persisted. This is a standardized PFGE protocol that PulseNet developed, and this took a lot of effort. In the laboratory, Dr. Efrain Ribot started providing the necessary expertise for developing an exquisitely standardized protocol which allowed us to reliably compare PFGE patterns generated on different gels on different days by different operators. Working with Dr. Ramesh Gautam at Washington State Public Health Laboratory, he developed a standardized PFGE protocol that could be completed in 1 day, which was a tremendous advance. Also, Mary Ann Fair and Efrain developed a robust quality control, quality assurance protocol that would be deployed to the participating laboratories to ensure that they were consistently able to generate PFGE patterns that were reproducible and could be compared across laboratories with a high degree of confidence. While the laboratory standardization was going on, Susan Hunter was investigating methods for computer-assisted objective analysis of PFGE patterns. The only commercially available system was one that was a clunky Unix-based system that was not very promising. Fortuitously, I was at a Listeria conference in Europe and ran into two brothers who were demonstrating their pattern analysis software. The older brother, who is shown on the right here, Paul Boiron, is an astrophysicist, and he had developed a software for his younger brother, Luke, on the left, to analyze DNA patterns on gels for his PhD in microbiology. And they were trying to market their software, and I was very impressed by their software and asked if they would work with us to develop a customized pattern analysis software for our project. That collaboration that began at that time has lasted to this day, and CDC investigators are using the next generation of the software, the bionumeric software, for their DNA sequence-based subtyping. Using the standardized PFG protocol, the QA/QC process, and the molecular analyst software, my colleagues in the laboratory were able to show that the patterns generated in different labs could be very reliably compared. And this one shows E.coli O157 strains from isolates from multi-states, 11 different states and CDC that were run in different laboratories, and you can see on the left that the patterns were indistinguishable from each other. We established a server at CDC to which the participating laboratories could submit PFG patterns generated by them, and they could query their server about the matches to their isolates and information on the isolates on the server. This really was PulseNet in action, and thus our vision of real-time subtyping to aid outbreak investigations of foodborne and diarrheal diseases became a reality. This slide is a comparison of the 1993 outbreak, which occurred before the inception of PulseNet, and a 2002 E. coli O157 outbreak that is shown in the bottom panel. The difference is striking. As you can see, PulseNet was able to detect the cluster of cases in the 2002 outbreak in about half the amount of time, about 18 days, which in turn allowed the epidemiologists to investigate the outbreak quickly and identify the contaminated product, get it removed, and thus preventing further illness. I just wonder sometimes if PulseNet had been in operation during the time of the Western States outbreak, and if we had been able to detect the cluster of cases in 18 days, what the epidemic curve would have looked like in that instance. This really led to the usage of the tagline, PulseNet saves lives, for PulseNet. And finally, PulseNet has always been a high-profile network of CDC. It was inaugurated at the White House by the Vice President of the United States in 1998. And in 1999, PulseNet won the Innovations in American Government Award for one of the most innovative programs of the government. And again, in 2002, we were recognized as one of the 10 most innovative programs of the federal government in the previous 15 years. And this slide shows my esteemed colleagues whose hard work and dedication made PulseNet possible, and the PulseNet administrators who provided a great amount of support to PulseNet at that time. There were other shifts in food safety besides PulseNet, and Patty is here to tell you about those.
So the outbreak drove a paradigm shift that opened the door to improved food safety. But first, let me take you back a year before the outbreak, when 11-year-old Damian Heersink developed bloody diarrhea and HUS. He spent 6 weeks in intensive care. His mother read the medical literature and became convinced that he had O157 and that he got it from ground beef on a Boy Scout camping trip. He was getting his food preparation merit badge. She became an activist for meat safety, and when she heard about the Jack in the Box outbreak, she reached out to parents in empathy. The parents decided to channel their grief so others would not suffer as their families had. That spring, Mary and other consumers formed STOP. Their goal was to improve food safety by telling victim stories. They were supported by other groups in the Safe Food Coalition. The child here is Lauren Beth, who died in the Jack in the Box outbreak. On the left is her mother, Ronnie Austin. On the right is Donna Rosenbaum, the mother of Lauren's best friend. Both were STOP co-founders. During the hectic days of the investigation, and Beth told you that went on for months, my division director stopped by to ask how things were going, and I sort of went on a rant. I said, we needed to use this tragedy to make things different. And he said, well, how? And I said, well, the first thing we need to do is get the labs to look for O157. So a week later, somebody's office stopped by again and said, I got you a special session in a big room at the American Society for Microbiology annual meeting in May. And I thought, well, me and my big mouth, how will we ever fit this into everything else we're doing? So in those days, Joy Wells and I did everything together on O157. So the next thing I did was call Joy, and I said, guess what? You're speaking at a special session at the ASM meeting in May. So after she calmed down, we decided I would draw in the crowds by giving the first national talk describing the outbreak, and she would tell them how to find O157, and we would both make it clear that they had to start looking for it now. So CDC then made a video recording of our talks and distributed it to public health labs. We encouraged viewing sessions followed by large question and answer conference calls to get advice from Joy. Public Health used the video to train clinical labs. And in fact, Minnesota sent it to all of their clinical labs. And John Besser, who's in the audience and was with the Minnesota Health Department then, said, we sent a copy to every clinical lab in Minnesota. Within a few months, many more labs had started testing. They sent us the O157 isolates for DNA fingerprinting, and we found outbreaks which helped us to prevent illnesses. By 1995, the percentage of clinical labs testing for O157 had increased to 60% from only 6% before the outbreak. And then back to 1993, in November of that year, Congress held a hearing on food safety. The Enteric Diseases Branch Chief Paul Blake and Mary Heersink, as well as others, testified. The outbreak drove changes that by 1994 included that USDA required safe food handling labels on packages of raw meat. FDA raised the recommended temperature of cooked ground beef from 140 to 155 degrees, and many states made O157 a reportable disease. And there was a much bigger change. So Mike Taylor is a lawyer who had just become administrator of the Food Safety and Inspection Service at USDA. In 1994, he made a speech at the convention of the American Meat Institute that shocked and outraged the industry. He declared raw ground beef contaminated with E.coli O157H7 to be adulterated within the meaning of the Federal Meat Inspection Act. Now, this was not a hasty decision. He knew that getting a new rule passed would take time. So he had studied the existing law and had decided to interpret it in this manner. So adulteration is a very strong word. It means that if E. coli O157H7 is found in ground beef, the meat has to be recalled. 20 years earlier, in 1974, the American Public Health Association had sued the Department of Agriculture, saying the wholesomeness labels on meat were misbranding, that labels should say that meat can contain organisms that can cause food poisoning. And USDA won, and the court decided that contamination was normal, and consumers must learn to protect themselves. So this time, in 1994, the meat industry sued USDA over Mike Taylor's adulteration statement. USDA won again, but this time it was a win for public health. The court said that industry must protect consumers, and that changed everything. Mike Taylor and his colleagues at USDA had already been working on something much bigger, a mega-reg, they called it, to decrease pathogens in meat. This would be the first major improvement in meat regulation since the Federal Meat Inspection Act of 1906, which consumers demanded after they read Upton Sinclair's The Jungle. In 1996, USDA succeeded in establishing the pathogen reduction rule that improved meat inspection. The meat industry had worked very hard against it. Kay Walksmith, who was director of the very new Office of Public Health and Safety and Science at USDA, said this: USDA had so many hearings about the mega-reg. The consumer groups were amazing. They were always there. The new meat regulation would not have passed without them. And there was more good news. In 1996, CDC launched 2 programs. Swami already told you about PulseNet, the lab system to detect outbreaks caused by E. coli and other pathogens using subtyping. We also launched FoodNet, the epidemiology system, to track the incidence of O157 and other infections and determine if food safety measures were working. By 2004, FoodNet documented a 43% decline in O157 infections compared with 1996. This occurred simultaneously with a marked decline in contamination of ground beef. And there was even more good news. In 1997, the White House announced a $43 million national food safety initiative. The photo shows Laurie Garand at the announcement. She joined STOP after her 3-year-old daughter, Anna, survived HUS after drinking retail apple juice contaminated with O157. So now Rob is going to tell you how these improvements in surveillance and funding contributed to food safety since the outbreak.
Well, thank you, Patty. PulseNet grew from 4 states participating in 1996 to all 50 by 2001, along with labs at the FDA and the USDA. It started with O157 and then added Salmonella, Listeria, and other pathogens. As the yellow bars here show, back in 1996, just a few hundred PFG patterns were uploaded to the PulseNet database, growing to 60,000 a year more recently. This empowered state health departments and CDC to find groups of cases or clusters that were likely to be related because they had the same pattern. As the pink squares show, the number of clusters tracked at CDC increased from 40 in 2004 to over 200 a year more recently. Now, we've been talking a lot about hamburger today, but these investigations found other foods where prevention also needed to be improved. For example, in 2006, there was a large nationwide outbreak of O157 outbreaks that was rapidly traced to bagged spinach. This was a wake-up call to the produce industry. In 2009, raw commercial cookie dough was the source. This raised the question of whether flour itself might be contaminated. Now we know it can be. And in 2010, an outbreak was traced to the Dutch cheese from Gouda, contaminated during cheese making. Now, at the same time, besides these examples of outbreaks, PulseNet also helped find many more outbreaks caused by Salmonella and other pathogens. For example, in 2007, a large nationwide outbreak was traced to frozen pot pies. In 2009, it was peanut butter and many food products that this flavoring agent wound up in. And in 2010, a nationwide outbreak was traced to shell eggs. These and other outbreaks led to many immediate changes that prevented illness. Indeed, it's estimated that PulseNet and the investigations and interventions it led to returns $70 in healthcare savings alone for every dollar spent. The many outbreaks also led to new legislation. On January 4th, 2011, the Food Safety Modernization Act was passed that gave FDA new rulemaking authority. This was the biggest advance in food safety for FDA in over 70 years. It called for new rules to protect and improve the safety of fresh produce, like the spinach, for processed foods, like peanut butter, and for imported foods. After several years of hard work, these rules were finalized in 2016. And now PulseNet itself is getting an update. In 2013, we started testing a new subtyping method based on whole genome sequencing. With partners at FDA, USDA, and National Institutes of Health, we looked at Listeria bacteria first. Using sequencing meant that we found 3 times as many outbreaks each year than we had before using just PFGE. And we found them while they were smaller. We also found new foods could be sources, each of them now getting more attention in the prevention arena. With this success for Listeria, we are now deploying whole genome sequencing as the new technology for PulseNet to all states, for Listeria, for O157, for Salmonella, and for other organisms. That transformation is happening very quickly this year. Now, the press has been an active partner, along with public health and regulatory colleagues, researchers, and consumers. All these recent outbreaks in the headlines were detected by PulseNet, and more than ever, public health authorities are empowered to find and stop outbreaks, to find gaps in the food safety system that can be closed, and to make the foods we all enjoy safer than ever. Now, you know, Beth Bell, the EIS officer in Seattle-King County, had a distinguished career and went on to become director of our center. Beth, what do you think about the impact this outbreak has had beyond food safety?
Thanks, Rob. I did just want to take a couple of minutes sitting here at the table to reflect on how I used, oh, good, you have the Patty's license plate up there, that's good. To reflect on how I used the lessons of this outbreak that we've just been talking about over and over during my 6 years as NCEZID director to bring home the benefits of public health to many different audiences, you know, in meetings with HHS and the White House and briefings and testimony on the Hill and interactions with partners. The story of this outbreak and what grew out of it helped to engender support for building the food safety budget, for establishing and funding the Advanced Molecular Detection Initiative, AMD, and broadly strengthening support for CDC's work in infectious disease outbreak detection and control. And I just want to take a couple of minutes to focus on 2 points. First, the outbreak and the improvements that followed, including the formation of PulseNet, serve as a model for the power of laboratory science as a driver of outbreak detection, ultimately shortening outbreaks and saving lives. I often contrasted the situation pre-outbreak when it took critically ill hospitalized children to raise the alarm with the early cluster detection made possible by PulseNet, not only to find local clusters more rapidly, but also to identify multi-state outbreaks. This served as a concrete and easy-to-understand example of why we need strong public health laboratories and strong public health in general. And it also, allows to highlight the importance of some of these underlying principles like the active involvement of state public health, the importance of standardization of methods and definitions, and the essential role of epidemiology. Telling the story of PulseNet was one of the most compelling tools I had as I went to Washington, D.C. In 2011, 2012 to explain why it was so important to fund the Advanced Molecular Detection, the AMD initiative. People could understand the need for PulseNet and its importance over the years, but also the vulnerabilities of continuing with 20-year-old technology and the promise of improving outbreak detection and response, as well as other benefits that next-generation sequencing and related innovation could bring. And as you've heard, the $30 million per year funding that we are receiving for the AMD initiative is indeed helping to implement the next generation of PulseNet. But the benefits of telling this story extended well beyond food safety and PulseNet to include other priorities like antimicrobial resistance as an important example, and the laboratory response network. Second, the outbreak helped me explain how all public health is local. So many folks in Washington, D.C. are very focused on the federal government, thinking that it's just a matter of swooping in and fixing things. For public health, this is, of course, very far from the truth, and we need strong state and local public health to effectively do our work. People could see that detecting and stopping this outbreak was all about alert clinicians, a well-educated and aware local medical and public health community with the right kind of expertise, and the availability of appropriate laboratory capacity and methods, and that collaboration among the various sectors locally, including the industry and the public, were pivotal. I just want to make one other point briefly. For our food safety efforts to be most effective, CDC needs to work with the relevant regulatory agencies, namely FDA and USDA. All three agencies have a part to play in addressing the deficiencies that were identified by the outbreak for CDC in the states, the groundbreaking advances in surveillance, for USDA implementing regulatory policies to reduce contamination on the farm and the slaughterhouse, and for FDA implementing a broad range of regulations relating to cooking temperatures and other food handling practices, as well as fundamental improvements in food safety for a broad array of foods, culminating in the passage of the Food Safety Modernization Act. So these early joint efforts all focused on a common goal and started a process of strengthening our collaborations that's continued to improve up to this day. So it's been a unique and affirming experience to watch the lessons from this outbreak that started my career in public health unfold over the decades, and I look forward to hearing your thoughts and comments. Thank you very much.
We're now glad to take questions or comments from anyone in the audience. There are microphones on the side, and we'll have microphones at the desk. Please keep your comments or questions short and identify yourself. And raise your hand if you're John Kobayashi?
No, John Kobayashi, I'm the state epidemiologist. And during this time, and I echo Beth's comments about the importance of local public health. One thing I very frequently tell people is that almost all public health decisions have to be made with incomplete information. You never have everything that you need. We didn't have a positive culture. We knew that 13 out of the 66 restaurants in the distribution chain that we had in Washington State were named. Why weren't the other ones named? And while Beth and Marcia Goldoff were gathering case information, I was talking with the managers of Jack in the Box and the environmental health people about what other scenarios like contaminated bread, food, vegetables, milk, et cetera, could have explained this outbreak. And we came up with nothing except that we really believed in our data and the quality of our interviews, which largely depended on the local health departments that we involved. We would have meetings every 2 weeks with the biggest health departments, local health departments in Washington, talking about communicable diseases for the previous 10 years. And we knew each other and we trusted each other. We were a well-oiled machine. And so even though we didn't have all the answers, I thought that we had good data and we went for it. I think another thing to think about is the legacy of people from the CDC who have contributed to this effort. A ton of people were mentioned, but I'll just mention that we were the first state to have E.coli O157H7 reported in the United States. The backstory is we beat out Minnesota by 2 weeks. I think it was the only time I ever beat Minnesota at anything. But the background to that is I was lucky enough to have someone doing a cohort study of O157 with Chris McDonald and Mike O'Leary. And documenting that it was a problem. Patty Griffin was there with Steve Ostroff, my EIS officer, working up another outbreak of O157. And Richard Dicker, who I think many of you know, spent a couple of years in my office, and he was tromping all over Washington doing regulatory reform, revising our rules and regulations. And so it was a kind of no-brainer to have O157 added, but it wasn't an accident. It was through a lot of work of a lot of people. So thanks.
Yes, Jean Smith, NCIRD. Beth, I have a question for you. You might have addressed this, but if so, I didn't catch it. Why was Jack in the Box the only fast food restaurant affected and not the others?
Well, the relevant meat was manufactured in a Jack in the Box factory in Southern California. So that's why this particular outbreak involved the Jack in the Box restaurants, because that's where the meat was supplied. Now, of course, as Patty and Rob and John have implied, it wasn't as though we were doing a great job of detecting O157 outbreaks, and so it's certainly possible, if not likely, that there were similar scenarios happening in meat, in patty preparation plants for other fast food restaurants. But that's why this was Jack in the Box outbreaks, restaurants, because it was Jack in the Box meat.
Hi, Dan Salson, OPHBR CDC. Thank you so much for this, and thanks, Harold, for starting this. What a great session. It's so wonderful to see you all and all the pictures. The lab has come so far in the time frame that you've described. Can you tell us something about how epidemiology has changed in that time period?
So epidemiology has come a long time. Things have changed a lot. In the enteric diseases branch, the bread and butter for EIS officers used to be going out on outbreaks, and you heard about the ones that would go out on these outbreaks. But that's sort of not done anymore, and people are always over their heads in multi-state outbreak investigations, investigating 30 to 40 at a time will be known, and we can't investigate all of them. So we'll pick the ones that are most likely to
Get an answer. Whoa, sorry. Now you can hear me. So that's changed. Because of PulseNet, we're finding these multi-state outbreaks that we think were occurring all along. And in fact, we're worried that if people stop getting isolates because of the new culture-independent diagnostic tests, we could go back into the dark ages where there are multi-state outbreaks and we're not finding them anymore. And when there's an outbreak, people think, oh, that's just happening over there. So things have changed remarkably, and because we're doing so many multi-state outbreak investigations, we've markedly refined our methods for investigating multi-state outbreaks, and we can do it a lot faster, and there's a lot more and better coordination with the regulatory agencies. So just briefly, that's some of what's changed.
I'll just add for your edification, Dan, that I think some of these sort of improvements in epidemiology that the food folks developed kind of helped with some of the early models for the Emergency Operations Center and incident management, and how all the state health departments communicate with each other in the context of an outbreak, even things like visualization methods. And so I think there are actually a number of methods that we now use for lots of emergency responses that maybe got their start with these guys.
Yes, I think Dr. Jean Gagarosa from the Emory University School of Public Health is next.
How do I turn this on? It's on. I'm Jean Gagarosa, class of 1964, and I remember the first EIS conference I attended, and I was so impressed with Alex Langmuir's presentation of his cutter incident. That really turned me on. And I've been impressed how well the EIS has done since then. And I think you guys who investigated this outbreak are really wonderful examples of carrying Alex Langmuir's epidemiological torch to the world. I congratulate you. I do want to mention one other thing. I left CDC in 1978, my first of several retirements. And I remember participating with Patty, you mentioned his name, from the University of Georgia. What was his name?
Mike Doyle.
Michael Doyle. I remember getting a call from him about late 1993, 94, asking if I would serve on the Department of Agriculture's food, FSIS, the Food Safety Inspection Service. And I said I would be pleased to do that. And as a matter of fact, it was that committee, after the presidential hearings that you mentioned, Patty, that I was with the committee that drafted part of the Federal Registry narrative that was then incorporated and signed off by President Clinton in 1997. So I wasn't involved in any of this investigation, but I had a very small role in helping get the HACCP strategy incorporated into that Federal Register action, and I think that's now become the food standard for food safety. Thank you, and congratulations.
So Steve Monroe?
Yes, Steve Monroe, Associate Director for Lab Science and Safety, and I'm not sure who's best positioned to answer this, but you mentioned in this outbreak and many others the role of the astute clinician in sort of recognizing the cases and recognizing the pattern. And you also touched on the importance of the company in sort of recognizing what was going on and taking the corrective actions. And so my question is this: is there a sort of a model of an astute executive? I mean, the person at the company who recognizes that, you know, it's not a time to be defensive, and it's a time to, you know, recognize the problem and be proactive and prevent it from happening again in the future. And I think you've seen that with some other companies as well.
I think that's a really key point, Steve. And in fact, the evolution of the attitudes within the food industry and the development of something that the food industry now calls food safety culture as a driving culture within the company has been rapidly growing over this whole time we've been talking, since 1993. And we have seen many companies turn to food safety specialists and food microbiologists, of course, playing the key role, to become part of the C-suite or become critical advisors to the C-suite, because companies recognize that they have great interest in keeping their customers healthy and are at great risk when they don't. And that's been a profound change in many companies. Not all, but there's been a steady evolution in that field.
Yes, Susan?
We have a question from Facebook Live from Jordan Michael. Does CDC work with restaurant reviewing websites or apps to collect data pertaining to establishments where people have fallen ill after eating at them?
Yes, there have been some interesting explorations in city health departments. I can think, for instance, of a recent review by New York City using Yelp as Yelp reviews as a place to pick up on possible outbreaks, as one more sort of consumer-reported, consumer-driven surveillance.
Well, not so much of a question, but more of a comment about implementation of whole genome sequencing. PulseNet did the first sequencing with the cholera strain from Haiti, and we used that information to figure out where the origin of the strain was in India. And when we saw that power of the method, we initially or immediately realized that this would be powerful for real-time surveillance. And it took a couple of years before we figured out what we needed to do. There was a lot of retrospective analysis done with whole genome sequencing, and they also seemed to point in that direction. But we know that we always need to have a success story, a real success story, in order to persuade the decision makers to invest in a new technology like that. And in 2013, we realized that success story, we could do that fairly cheaply by doing real-time surveillance of listeriosis. And 2013, that was one of the sequester years, and we really didn't have any money to do anything. And I would like to comment, Chris, and especially Beth, because you found the money. Not that much money, but enough money to complete that study. And, well, as they say, the rest is history.
Yes, John.
Thank you for a great presentation.
That was Peter Gunnar-Schmidt of the Enteric Diseases Laboratory, and this is John Desser.
Thank you for identifying me. Food is because I forget. Food is, of course, a global commodity, and there are many chapters of PulseNet exist all over the world now, and a lot of the groundwork was laid by Dr. Swaminathan. So I'm wondering, how do you get different countries to agree on anything? And furthermore, could we use these techniques that you used for world peace, or what would?
World peace, huh? That's an interesting one in today's age, given the situation we are in. It took a lot of effort to get the international part of PulseNet going. We had a relatively easy time with Canada, and as you know, we signed a high-level agreement between the ministry in Canada and U.S. Department of Health and Human Services for sharing patterns in real time. That was a monumental achievement, and Peter was also part of that agreement, signing of the agreement. In Europe, it's been a very difficult situation because different countries want to have their own agenda pushed forward and are not interested in joining a standard. They took us forever to get Europe to sign on to PulseNet. Asia, we had a much easier time convincing people, but then they had other problems with respect to resources in particular. Getting some of the bigger countries involved, getting China signed on, helped really get the Asia-Pacific going. And then Peter has been doing extremely well with other parts of the world. Yes, internationally, it's been quite difficult to get people around this, but I think we have managed it, and you all have managed it, taken it to the next level. And I might add that sometimes to get that buy-in from within CDC is even more difficult than international.
I'm sorry, we're out of time, but I would like you to take a moment and thank our speakers and to acknowledge the other people who work in this field. If you're interested, there is a display down in the library, and also the program has requested anybody that has worked in this area to please come forward and we'll take a photo. Thank you.